So we're going to move into talking about care coordination and case management. We have a polling question to get started, and these are two true and false questions. So we're going to do our first one. Coordinating patients' care properly can mean the difference in the patient's healthcare outcomes. True or false? Okay, everybody seemed to got that answer correct. Yes, that is true. Okay, our second question is, having a checklist of items which are appropriate to share about a patient helps maintain confidentiality. True or false? Oh, good, everybody was listening to that yesterday. So yes, the answer is true. All right, so moving on, I'm gonna try to make this where it's not really monotoned and we don't have a lot of engagement during this particular presentation, but of course I'm open to any questions that you might wanna ask throughout the presentation. Put those in the chat box at the bottom like you have been doing the last 3 days, and we will get to them at the end. But I am going to try to make this engaging because I think this is really important for all of us. Even if your role is not strictly doing case management work, we all do case management work at some time in our practice. So I think it's really important, and over the last decade, maybe a decade and a half, there's been a lot of focus on really trying to make sure we're understanding the needs of our patients. We all have our own opinions about what we think patient care should look like. And not that those opinions are not important, because they are, but you want to make sure that when you're taking into consideration the ideas that you think are important for our patients, that we look at what the patients think are important for themselves. So our patients really need to be partners with our healthcare providers and provide insight into what they think their goals are for themselves. And that way we have a better clinical perspective, and we can kind of take out some of those emotional, mental, spiritual, social, and financial perspectives and put them in to a place that really looks like we have spoken to the patient and we've gotten their engagement in what we're trying to get them to do. Like Joan had said in the post-test, we could have all kinds of ideas about what someone should be doing, but if that person has not bought into their own treatment plan, it's really hard to get them to change. And I know sometimes it takes a lot of effort for us to be able to get to a patient to that place. You think about mental health therapy. As soon as somebody walks into their first session seeing a therapist, they don't walk out and all their problems have been solved. We need to look at that same perspective as we're putting all of our plans together and forming this multidisciplinary team. So there are many elements to patient-centered care, and I think these are things that we want to go over so that we really understand how to best put a plan in place that focuses on the patient's need. Healthcare systems have mission and values and leadership and quality improvement drivers that are aligned to patient-centered goals, and we really need to know what our institution's values and mission statements are as we're moving forward. We also want to make sure that the care is collaborative, coordinated, and accessible. The right care is provided at the right time and at the right place. So again, sometimes it's going to take a while for someone to get on board with you. Maybe sometimes that never happens. I mean, unfortunately, we've all seen cases like that, and the outcome usually is not beneficial to that patient that we're taking care of. But sometimes, like just when we were providing our plan to our C-suite individuals to get our medical home up in place, we were at the right place at the right time, talking to the right people. So we really need to look at that as a goal for us as we're moving forward and taking care of our patients. We also want to focus on the physical comfort as well as the emotional well-being of our patients. And in particularly with the sickle cell population, we need to be very sensitive to the fact that, for example, when they're coming into the emergency room, those extended wait times, how uncomfortable that might be for somebody who is in chronic pain. Are they cold? Is there some way for us to give them a blanket? Can we make sure that they have water? These are things that help keep somebody feel comfortable even as they're going through a crisis. And these are all patient-centered focus plans. Now, I know in an emergency room setting, that's always not an option. But if we could really think about that and work in partnership with our emergency department, that when a patient comes in and we know there's going to be a 5 or an 8 hour wait time, and I know those things are there and there's nothing we could really do about it, can we try to find a way to make them comfortable? Because they're already in a crisis. They will not come to the emergency room until they're at the point where they're not going to be able to take it anymore, so let's do our best to try to make them comfortable. And also, let's consider the patient and the family preferences. Their values, their cultural traditions, and the socioeconomic conditions are being respected. We all are in our own culture. Whatever your ethnicity is, wherever you came from, and whatever your values are, more than likely are different than the person sitting next to you. So, try to, if possible, to respect that as you are moving forward and planning for your patients. Also, you want to make sure that patients and families are part of the care team and play a role in the decisions of the patient and as best as they can at the system level. This is challenging on many levels. And I know that, we do try to get releases of information signed when we can, and especially when you're an adult, trying to get that, support system engaging with those patients, especially patients that you are feeling frustrated about, or that they may need some additional support, such as transportation to their appointments or making sure that their medication is being picked up. In order to get that family member involved, we need to make sure we're taking those proper steps to make sure we're protecting the confidentiality of the patient and the respect of the patient, but knowing that without that family support, we might still be frustrated, and that leads to us not being able to give that patient all of the outcomes that they deserve. Also, if possible, and I know with COVID, this has been a little bit more challenging, and hopefully some of these restrictions are being lifted or have been lifted, and it's something we could go back to prior to COVID coming about. But, there are times when it's important that family members do come to the care setting appointments and that they are part of the conversation. Especially, there's many reasons why. If you have a patient who has some cognitive impairments, maybe memory is an issue for them, and the physician's sitting there giving them all these instructions, and the patient's nodding that they understand that, and they walk out the door and they're like, either forget or I have no idea what they were saying. If you have a family member sitting there with you, one, maybe they could take some notes for you, or maybe they could think more clearly to ask some of the questions so that there's a clarification of what the expectations are of the provider. And again, making sure that if possible, you are sharing information in a timely manner so that both patients and their family members can make informed decisions. I know a lot of times patients will contact us as a follow-up. Oh, well, I took my UDS. Can you tell me if everything's okay so I can get my prescriptions filled? I know I had lab work done. Are you able to tell me, are my lab results okay? Now, in the electronic medical system, we know that most of the time now people could go into what we call here My Chart and be able to see some of those things. But if they're not computer savvy or they're just not really sure if they're reading things correctly, we need to make sure that that information is available so the anxiety of that patient or their family member can be significantly reduced. So I have done some research and tried to figure out, how is the best way to really present this to everyone and stay in focus with the values of patient-centered care. And there's 8 values that I felt are really important to go over. And we've talked about these over the last couple days in different respects. But I think it's really important that we respect a patient's values, their preferences, and express needs as much as we're able to. This is, again, maybe where a patient navigator or community health worker or social worker or clinical social worker or the nurse really can play a big role. They have the time to really sit with families, build a relationship with them and kind of know what their values are and how they may want to be perceived when they're coming in for their medical care. If you don't have those resources, then I would do your best to find somebody who could really sit down and spend some time with the patient to kind of figure out where they're coming from. If we don't understand where a patient's coming from, it's really hard for us to be able to, again, build that trust and partnership with them, but also be able to have them buy into their treatment plan. We also want to have that coordination and integration of care. Again, they can't sit into the team meetings most of the time. We Zoom every morning still at 8:30. We don't have patients sitting in those meetings. But by having our care team or our medical home team speaking frequently with those patients, we kind of know what their needs are, what they want, and how that conversation has gone between that party in our medical team and the patient. I'll give an example. Like I said, said, we Zoom every morning at 8:30. We've been doing this for 2 years with COVID, and we're going to continue to do this. And there's many times where we'll bring up a patient might have called overnight, or maybe they had come into their clinic appointment, or maybe they've been in the emergency room, and the perspective of maybe the provider at that point might be saying one thing, but then our navigator has had a conversation with that patient earlier in the day before they came into the appointment, and they're like, no, that's not what they were wanting. They wanted this, or this is what I think based on my conversation with them. That is really helpful for us to decide, are we going to move forward with the plan that we have in place, or are we going to want to take into consideration some of the things that were being relayed to us by the navigator? Information and education is also extremely important. I know in today's world we do everything electronically, just like you have your electronic manual and all of the things back when we did our original SCCAPE conference where we had this, this Bible of information that we passed along to everybody in print. We're really kind of focusing on everything in an electronic way. Make sure that that information is available to people. Sometimes because of age or literacy levels, like we had spoken about yesterday, maybe an electronic form of things is not the most appropriate. Think about COVID. If you've gone out to a restaurant and somebody's like, okay, scan that little bar over there so you can see what the menu is. Well, maybe some people don't have an iPhone or an Android phone where they're able to do that. So you have to say, can I have a paper menu? Same thing when we're giving information out to patients. I think it's really important to make sure that they have access to that information and education, and if it's not in a way that fits into what they're able to do, provide that to them in a way that is accessible to them. Again, physical comfort. I think I talked about that a little bit, but I can't stress that enough. We had a time when we had backpacks that we were able to pass out to patients in the clinic. It had a blanket, it had a water bottle in it, it had different things to provide comfort to them that they could take to the emergency room. Okay, well, that's great. Maybe not everybody has that or brings that with them to the emergency room, or when they're coming into an appointment and they're waiting for an hour or two and the waiting room is cold or too hot or however it's going to be. Make sure that you're aware and sensitive to that. Emotional support and really reducing the fear and anxiety. I don't have sickle cell disease, but I have been working with patients long enough to know there's a fear factor there, especially as the disease is progressing, or maybe they've just recently had a stroke, or they've been in a long hospital stay, or something has happened. That fear level is rising, and so you want to be able to provide comfort and support to them. Again, involving as many families and friends in any medical setting is really important, but especially when you're dealing with a lot of information, and again, maybe more so as disease is progressing. I also think about transition. We have these young people that are coming in, they are leaving the comforts of the pediatric care where everybody's known their name for 18 or 21 years, depending on where your practice is, and then they're coming into this stellar cold area of the adult world. Make sure that if possible, you have family and friends there to support them. When I was working in transition, my first job in working with sickle cell patients, we originally were like, nope, that first adult appointment, we want you to come in by yourself. You're a grown up now and we don't want your family members there. Oh, that was a huge mistake. So there has to be that transition piece where, the parents are feeling comfortable, or the grandmother or grandfather or the aunt or whoever that person is caring for them. Make that gradual transition into making that person a young adult, but always stay part of the conversation. They still need that support. Continuity of care, especially in transition, is important, and making sure we have access to care. Those are really the core 8 values of person-centered care. And if you can kind of keep those in perspective as you're moving forward, developing your teams, or if your teams are existed, try to maybe, review those periodically. Again, when I'm looking at this right now, these are not things we go over like bullet by bullet, but I know that we take these into consideration as we're moving forward on a daily basis talking about our patients. So again, what are the benefits of patient-centered care? Well, the primary goal is to improve an individual's health outcomes, and not just their population health outcomes. And even though health outcomes may be improved, we want to make sure that they're done in the right way. We want to make sure that patients are overly satisfied with how things are progressing with their care. again, I know it sounds like a broken record, but if someone's not happy with their care and the family's not happy with the way their patient is being treated, we need to figure out how we can make that better if possible. Sometimes that's not going to happen. Sometimes people have not bought into your treatment plan recommendations or the medication reductions that you're doing. But there has to be a way to try to continue to work with that patient, because ultimately, especially with sickle cell care, there's not many places where they can go. So I know in Virginia, we have now a new adult care team in Northern Virginia, but we don't really have a lot of adult providers in the state of Virginia. So where are they going to go? We're really the place for them to come to. So, they may fire us and then they come back and, all those kind of things. But the bottom line is, as clinical providers and people that are working with sickle cell patients, we want to make sure that ultimately they're satisfied so that their quality of life and the way they're progressing with their disease is working. We also want to make sure that we have, our healthcare consumers on board. That's why we're doing this conference. I think Dr. Smith was telling me that there's like maybe 1 hour of sickle cell education in medical school. So if that's really the case, and you're coming into this and you're like, I really want to deal with patients with sickle cell disease. I feel it's a health disparities. I feel it's a calling of mine. Whether you're a clinical provider, a patient advocate, whoever that's working on this team, make sure that the information is there for the health providers. Make sure that they come to conferences like this. Make sure that they get mentors that can provide them the support that they need. And it's also important to keep the morality of the team up. And that has been really challenging over the last 2 years, right? We've all learned how to practice differently. We don't see everybody every day. Many people have still not been in their office for the last 2 years. So, making sure that your staff are feeling like they're being appreciated. We do several dinners a year where our team goes out and, our wonderful medical director supports us with that. Or, we got to do exchanges where sometimes one of our nurses who loves to bake will bring goodies into the clinic, even though there's maybe not a lot of us there. She'll kind of give a heads up, hey, I'm baking today. If anybody wants anything, I'm going to be over here. All those kind of little things are really important. And also just, sometimes we're not really good about this, but I know if we're still doing Zoom conferences and everything like that, maybe sometime before we get started on our Zoom, how's everybody doing? What'd you do this weekend? Oh, you did this? What was that like? And exchanging information. That kind of keeps people's morale up and makes them feel like, hey, this is more than just a job. These folks really care about me. They're my work family. Resource allocation, we all know that that's a limited thing. Budget cuts are everywhere. Staffing cuts are everywhere. But if possible, try to look at places where you could get resources to help support your program. We've tried to do some very innovative stuff over the last couple of years. I'd spoken to you about, because we're a Commonwealth, we had to go to our legislature to try to get some additional support for staffing, to help our community-based organization. And it was years in the making. And pounding the pavement and meeting with senators and meeting with delegates and all that. Well, we finally got that to happen. And although, of course, we always could get more money, we're not dependent now on a couple positions that are going to be coming forward because they're being sponsored now by the Commonwealth and not by the hospital. And reduced expenses and increased financial margins are really just part of continuity of care. The bottom line is that healthcare systems need to make money, and they need to be able to allocate their resources in the best way that they can. So we have to be conscientious about how we are making sure patients are utilizing the system as best as they're able to. So we're going to have another polling question, and I wanted to really see with everybody that's on board here kind of where you're at as far as your program. So where does your program stand in case management development? 1, just started or no progress. 2, staff approved but not hired. Or 3, hired and trained. That's the answer? Okay. Interesting. Okay. So that's interesting that the majority of us are saying that you're still in the infancy stages of getting things developed, which is why I guess it's great that you're at the conference. But over a little under half of you really have hired and trained staff, and that's great to hear. I'm finding it interesting that nobody has really had staff approved, but they're not hired, because I find that that's something that we're battling all the time, especially now with the job market. You might have jobs out there, but somebody's not necessarily applying for them or getting hired because they're not the right folks. Okay, thank you for that. So now we're going to get into a little bit of care coordination and case management as part of patient-centered care. So care coordination is coordinating patient care properly, which means the difference in the patient's healthcare incomes or healthcare outcomes. So a lot of times, primary care physicians are the ones who are coordinating care. They are the ones who don't have maybe the resources to be able to go to social workers or case managers, and so they're doing a lot of the same things that other staff would typically do. They have to really provide that type of coordination because of the fact that the resources are so limited to what's out there. AHRQ emphasizes that care coordination necessitates communicating at the right time, again, to the right people, as well as investing in tools to assist them more effectively towards specific and immediate needs. This again, getting patients and families involved in their care, collaboration with other resources. Let's say you're in a rural area, a primary care physician is dealing with a sickle cell patient. They don't really have the expertise in really knowing how to deal with this patient. Maybe they're not aware of the new medications that are on the market. They will reach out to our team and say, hey, how can you help me? I have this patient here. They're not able to really come to your center. They're 2 hours away. They don't have transportation, but I really want to give them the care that they need. That's what we're here for, is to collaborate with other medical personnel out there so that we can try to get families and patients the care that they need. Now, the Case Management Society of America defines case management as providing healthcare professionals working with people to identify issues and barriers that may prevent them from getting better and uncovering mutual agreed upon solutions to achieve their healthcare goals. That's a mouthful. So what we're talking about here is that you now have staff that are willing and able to go in and do case management services. Many times, this could be your nurses, this is your social workers. If you don't have patient advocates, these are all the folks that we've been talking about over the last 3 days. And I'm sure those of you that are sitting in the audience out there saying, yep, that's what I do. Johnny came in today. He didn't have breakfast this morning. I made sure he had a hot meal. He told me that he had to stay in a shelter last night. I need to make sure that his needs are being met. How do I properly plan for this person long term? This is where your assessments come into play. If you have that licensed clinical social worker, maybe you're asking them to see this individual to kind of gauge, like, where are we? Is this patient suffering from depression? Is there some kind of undiagnosed mental health treatment that we need to get for them? What kind of planning are we going to have? Every time he comes in here, it's the same scenario. He hadn't had breakfast. It looks like he hadn't had a bath for a couple days. His medication doesn't seem to be all there, and he's not really sure how to take it. These are all part of that whole case management processes, and it's long term, and there's multiple people involved. But sometimes it's just one person who has to do this because you don't have the resources of that whole team. So I really feel for all of you. And I've been there. I've been there when I've been doing, obviously I'm not a nurse, so I can't do the clinical piece of it, but I've been there when I've been trying to pull things together and trying to network with some community resources to try to get a patient stabilized. And most of the time, if you know what you're doing, you're able to get those things accomplished, but it is very frustrating, tedious work, and you really have to have the patience to be able to do that. Your job ultimately is to advocate for that patient, and so that's a really big component of case management. So going back to care coordination, there is really 4 main components to care coordination that are really part of that patient-centered process. Satisfaction, achieving a patient or family goals like we've talked about several times here, reducing unmet needs, and increasing provider and staff satisfaction. Again, I can't stress this enough. It's really hard to get people to want to come and work with sickle cell patients, and there's multiple reasons for that. And it's of no faults of anybody. But, we want to make sure that those folks that come in and work with us, they are satisfied with their job. They are felt like they're listened to, and even though sometimes we don't have the solutions to be able to solve the problems, sometimes it's just having an ear for somebody to vent. I get phone calls a lot from people that just say, I just need 5 minutes to just soundboard off of you. I'm okay with that. That's what my job is. And we kind of talk through things and they feel better and they go on and, the next day everything's fine. The function of care coordination, which is easy access to resource information, achieving those self-management skills, enhancing communication again between providers, family, community partners, increasing the functional abilities of the patient if at all possible, support achievement of optimal development trajectory. What is the long-term plan here? A single point of entry into multiple services. This is where that community health worker, patient navigator, social worker really comes into play. Can they be that single point of contact for this patient? And I'm going to tell you, in our practice, it is. They know how to text our patient, our patient navigators. Our patient navigators know how to get a hold of them. We have this cell phone system. It's a little annoying, but we still use it every day. And all of us have, cell phones that were given to us as part of our medical home. And we have a team chat where all 16 of us are on this chat. And if something comes in, whether it's a text from a patient about a medication refill or whatever the situation is, we're communicating in that chat all day. Sometimes we miss things, and sometimes then we bring them up in the morning. But we have found that single point of accountability probably is falling mostly on our navigators. And I can't say this enough. During COVID, they really were the lifeline to our entire team. The patients felt trusted enough, they had built relationships with them, and they felt trustworthy enough to reach out to them no matter what the circumstances were, and then they would relay those facts to us until we kind of, figured out a plan and a system that really worked for everybody. And of course, providing positive social supports. This is where your community-based organizations could come in, and, I really hope everybody can stay till the end today, because we have really 3 different perspectives of CBO work. One of them is a wonderful woman out of California who has developed an excellent system throughout the state of California for sickle cell support. And I think that is really something that is imperative, as well as maybe, using social networking. And in our case, we're starting to build those support groups within our institution, because it's important sometimes to have that separation. Community-based organizations have an agenda. We have an agenda. Sometimes the agendas are not the same thing, and there's different outputs that need to be available to patients. All of these things are positive. One thing is not better than the other. We all have to work together to make those things happen. And then we have the clinical component. We enhance the communication among providers, the family, the community, increasing the measures of health. That is really, really what we're looking at to do these days. Increasing activity, developmental screening and health promotion. You heard Dr. Smith talk, I think it was yesterday or the day before, how we're really looking to try to get echocardiograms on all of our patients, how we want to have a continuity of how often we do, UDSs and lab work, and how often are we reviewing charts and treatment plans and making sure they're up to date. Improving access to health and mental health care. If nothing else has been demonstrated through this pandemic, it's the mental health of everybody, not just the patient, but the providers. And like I had spoken about yesterday, if we are not good up here, it's hard for us to take care of other folks. We need to be better about taking care of ourselves. Self-care, I think Rachel spoke about that also in her talk on Tuesday or Wednesday. Self-care is extremely important for all of us. And no matter what your job is, no matter what you do every day, you need to make sure you're taking care of yourself. And lastly, we have the cost of care. I don't ever want this to sound like for a hospital, it's always about money, but these are things that are of reality. If hospitals don't have the income to take care of patients, they're not going to be able to continue to staff the hospitals the way they need to and be able to provide the support that they need to be able to do. So we do have to be sensitive to the fact that there are things that we need to work at internally to try to bring down the cost of healthcare. So one is remove unnecessary emergency department visits. If you remember Keith's story, there was a reason why Keith kept using the emergency room. Let's figure out why that is. And over the course of the last 4 years of this medical home that we have, this has been one of our main goals, and we've done a pretty good job at it. And that's because we have the resources, the partnership, the champions that we've spoken about to be able to get patients to start trying to come into their healthcare appointments more often and be able to stop using the emergency room for unnecessary emergency department visits. Also reducing your hospital stays. Remember when I talked about our previous nurse practitioner had left in 2014 and we had a gap of 3 years where somebody was actually taking care of our patients where they were in the hospital? Well, they would be there for 2 weeks. And, nothing was really changing for them, but they would be there for 2 weeks and we couldn't get them to leave the hospital because their pain wasn't under control. Now, with the staff that we have, the tiered oral therapy plan that we have, and the buy-in of champions in the hospitalist system and inpatient care team, we've been able to significantly reduce those hospital days. Also making sure that we're not duplicating tests and services. This has really been great for the electronic medical system. And now, we just joined the Epic system, even though it's been a nightmare as we're transitioning over. Epic is really one of those systems that is being used more nationally around the country. So you're able to see that if, Susie had been in the emergency department in another hospital and they had already run an EKG 2 days before, why would you want to run that same EKG if she just comes back to see you again? And reducing repeated data gathering by service providers and also reducing caregiver work days lost. We all want to go to work, whether sometimes we like our jobs or we don't like our jobs or we're having a bad day. We have to go to work for various reasons. It's really stressful when you're not feeling well and somebody can't get back to work because their care maybe hasn't been met in the way that they needed it to be. So, how did we get to where we're at today? Well, I haven't been around a long time, but I've been around long enough to know that, physician practices have changed over the years. Physicians were definitely more autonomous 30 years ago in their practice. They were the leaders of their firm. Many of them had their own little offices that you went to. They weren't really attached to a hospital. There really wasn't that overhead of all the resources that were available to them. But they took care of their patients, and they had their nursing staff or their one secretary out there to make sure that appointments were being rescheduled, that nurses were calling patients if they had to give them the results of their testing. But it was just really like a mom and pop type of organization. And most of the time, patients just went to the doctor when they felt ill. Maybe they would go if they needed an annual physical, but most of the time it was that they just went when they needed to go and that they weren't necessarily saying, it's been 3 years since I've been at the doctor. Why hasn't he called me? I haven't heard from him. I'll get back there when I can. Well, today that's changed. And so many times, you're going to get these reminders that, you might be due as a woman for an annual mammogram that you haven't gone to have, or, someone's just following up because you were supposed to come back in 3 months. It's been 6 months. They haven't seen you. There's that whole treatment dedication to patient care. And that is really something that maybe could be seen as annoying by some folks, but I think in the most part, it's really trying to improve overall patient health. And we also have these multidisciplinary teams where, you may not be, as the patient, the person making those decisions, which sometimes take that autonomy away from you. But if you're using that whole patient-centered approach, you should be part of that planning, even if it's through a provider that you're dealing with, like your navigator or your social worker. And again, we have to make sure that we're taking patient values into play here. I don't think that probably happened in the old days. Physicians or providers were, taught to come in and, again, no fault of their own, taught to come in and be able to, do A, B, and C. And maybe it was a one-size-fit-all thing. And now that's very different for everybody. So I want to move on to the development and framework functions of community health workers. I think it was yesterday that Joan touched lightly on this and said that we were going to get into more in-depth about this. And we wanted to make sure that we kind of told you where we were coming from when the article was written of how we developed the framework for those 4 types of community health workers. So it's the 4 people on this conference panel that were part of that manuscript, as well as another individual, where we really got together and felt that we needed to really more clearly identify the uniqueness roles of community health workers and how do we promote them in a way that could maybe help with the healthcare system employing more of them, with community-based organizations understanding the roles that they had in using community health workers, and how health navigators really were that higher level of high touch with patients. So there is evidence to support that the effectiveness of community health workers is of a wide range in many healthcare settings. The perceived value of CHWs suffer from the lack of uniform credentialing. I know there are some states, I think Minnesota's on here with us today, and I think Ohio's on. They've been instrumental in really trying to help with that uniforming of credentialing, but most states are still really not there. And there's been a real big change, according to what Joan was saying yesterday, of how that really should look. The billing and payment structures for the work that they do. I feel in our role at the hospital that we do a disservice to our institution because our patient navigators do an immensely amount of work that they cannot submit for billing purposes for reimbursement through Medicaid or Medicare. I think that's a lot of money that's going out the window for the healthcare institution, but we haven't been able to really figure out how to make that happen. Obviously, we have conflicts of job titles and position descriptions. I mean, I think Joan said yesterday she was up to 67 different titles for CHWs. Well, you know, each of those individual job descriptions also look different. The job description that's in your electronic manual is the one that I put together for our patient navigator program, but I also know on the healthcare system side, they call them medical outreach workers, and they have a different job description for them, and they have a different pay grade for them. So, you know, we're really trying to get, even within our own institution, recognizing the uniformity of using CHWs, making sure that the pay scale for them is appropriate with what their education is, and trying to move forward to really support this position because it's really critical. Okay, so this is going to be where we talk a little bit about more in depth what Joan had spoken about yesterday. So there's 4 types of community health workers that we came up with. It doesn't always mean that what we said was right, but we really looked at this long and hard to try to figure out how we were going to be able to identify and recognize the education and the commitment that each of these particular categories put towards the roles of what they're trying to do with our sickle cell patients, but also recognizing that there's overlapping of many of these roles. So if you look at this diagram, you're going to see there's 3 different categories that we put here. The clinical social worker, which was the role that Rachel and Alicia are in our institution. We have the patient navigators, which are in our case, Nakia, Stephanie, and Marla. And then we have our nurses in our adult program, that's Kate and Justin. In the pediatric program, they have their own nursing system. But you're also going to see that there's a time when some of those roles are overlapping. And I think that's really important depending on where you're at in your institution and the staffing that you have, that again, you're able to recognize where those things come from. So clinical services are something that only nurses are really able to provide. You know, even as high of a licensure as like Rachel and Alicia have, they are not medical staff. So the nursing role is really significant because they can really provide support for mental health treatment, they could propose medication, they could be able to really be that bridge between the clinical provider and the behavioral health team. But we also have the roles where we have that case management that's overlapped really between all of them, and each of those groups are also able to be part of a peer support group. So I want you to be able to look at this more intensely. You will be able to access these slides at the end of this presentation. So I think it's really important that you spend some time on this model to really understand. I mean, if you're living it every day, you know what it is, but the integration of how these players all come to be and the importance that they play in our system. So first, let's talk about the peer community health worker. So this is a role that's been around for many decades. You heard Joan speak about it when she was in the health department, you know, and how it really kind of worked out many years over time in probably multiple states about someone who really kind of could relate to the person that they're dealing with. This has really become instrumental over the last probably 20 so years of the Ryan White organization and dealing with patients with HIV. There's a lot of peer mentoring that goes on there, and also a lot of peer mentoring with people who are battling substance abuse. So when we were putting together our article, we were trying to come up with what we thought were the qualifications and functions for each of these different positions. So the qualifications that we feel that the peer community health worker has is, of course, sharing that common demographic with that targeting population. Again, that's the HIV population. It does happen in our sickle cell population. It's not consistent across the 50 states, but there are obviously peer community health workers. I mean, we have one of them in our community-based organization. They don't necessarily have to have a minimum education requirement, and the CBO or institutional programs can supervise these individuals. Their functions are usually a little bit more boots on the ground, but they assist with system navigation and community resources. Sometimes that person is going to be the one that's going to get that patient who might be, let's say, utilizing the emergency department for their routine medical care as the way for them to deal with their disease. That particular peer community health worker might be actually able to get that patient to come to that first appointment. They could also provide education of the disease. I mean, if they're a peer community health worker and they have sickle cell disease, they probably know their disease better than most of us do. They can provide that education and support to another person without feeling like they're being intrusive. They could also advocate for them, provide that emotional support because they could relate to the situations that they've been experiencing. They could provide direct service. They could conduct outreach and case findings, and they could assist with community assessments. And so that is the first of the 4 roles that we felt was really instrumental and probably the easiest to almost implement. This one here, in my opinion, kind of overlaps with the next one in a lot of ways, but it was really a term that we felt we really needed to be able to identify. Instead of just saying that there was 3 types of CHWs, we really felt that there was that 4th one, that general community health worker. And like I said in the previous slide, there is going to be overlapping in some of these roles. So if you'll look at the functions as we're moving through the next 3 types of CHWs, you're going to see the ones that have an asterisk and underline somehow overlap with either the previous CHW role that we spoke about or the next one that's coming out. So for the general community health worker, we feel that they share conditions, demographics, or experience with targeted populations. They typically will have a high school diploma or a GED, and many times they could be supervised by a community-based organization. Their functions are that they assist with system navigation and community resources, which is very similar to what we talked about in the previous role. They can conduct cultural competent education with direction or supervision. I believe that Joan talked about this yesterday, and I feel this is really significant. Sometimes people are training people to be CHWs and then they let them off and they go about their merry old way and nobody's really kind of overseeing what they're doing. That could really become a liability for somebody. Sometimes bad things just happen. And so it's really important that there's an overseer, like there should be really for any of us. And so I want to make sure that that is something that you're all keenly aware of. They advocate, but also they're advocates, but they also advocate for populations based on needs. They do provide that emotional support, which I think is going to be across the board for everybody. They provide direct services within the CHW scope of practice. They conduct outreach and case findings. They participate in evaluation, research, as well as assisting with community assessments. So you'll notice in that particular one, we didn't say that was the evaluations and research piece coordinated with any other of the 4 groups that we're talking about, but this particular group also could do community assessments just like the peer community health worker. So then we have the clinical community health worker. And so this is the one that this one and the health navigators are really the 2 that probably are working in the healthcare systems. So their qualifications, they may not have sickle cell disease or whoever they're working with, they may not have that condition. Their demographic or experience with targeted populations are there, but they have a keen interest in the population without necessarily being part of the population. They do have to have a GED or a high school diploma or they may require post-secondary education. When we put together our navigator position, we did indicate that that particular position did not have to have a bachelor's degree. We would and still would consider somebody that has a GED or a high school diploma, because sometimes that experience is going to come more into play than if they have their BSW or related health field degree. They are supervised by a degreed professional within the medical system. That is absolutely significant. You are not going to find a healthcare system that is going to allow somebody to come in and do CHW work without having somebody with some type of professional degree overseeing the work that they're doing. Their functions are much more intense, where they provide system navigation and community resource connections. They enhance the system resources and provide care coordination and not case management. So this is really instrumental in what we're talking about of the role of the clinical community health worker. They are going to be the individuals that help you or help someone you love or care for navigate the healthcare system. Even those of us who work in the healthcare system sometimes have a hard time navigating the healthcare system. So imagine if you are struggling with multiple appointments, you're not sure who you should talk to for what this testing needs to be done. Maybe you have a problem within the system. You don't know, who to really report to, whether it's patient relations, who you should talk to about something. This is the role of this individual. This is the work that our team does every single day. They may develop education and conduct cultural competent education with supervision. So we do have many resources, some of them that are in your electronic manual, that are public domain resources, as well as resources that we've come up with ourselves that are part of the education process for our patients. They may advocate for patients or be involved with medical conditions, but they must do that under the umbrella of their employer. So sometimes there are limitations to people that work in this particular category. Where I think it's sometimes hard for families or patients to understand that there are sometimes lines that have to be drawn in the sand that maybe we don't necessarily want to have drawn, but because of where we work, we need to follow the guidelines of that institution. Be supportive by linking the patient between the medical system and the community. Even though I like to believe that all of us are community resource savvy, we also know that that is not the case. And sometimes over the years, it's been really disturbing to know that the simplest little thing that a patient needed was available to them at their fingertips, but somebody didn't have I don't want to say the time, but they didn't have the ability to kind of help them get to that next step. That's what this particular person is able to do. They're able to provide direct service as delegated by the medical team. They conduct outreach and case findings, but also participate in formal activities of patients in clinical services, and they participate in evaluation, research, and assist with community assessments and gathering patient data. All of our navigators, all of our people on our behavioral health team, I think I had mentioned to this maybe the other day, we document everything not only in an Epic system, but we also document things in REDCap. And there's a lot of detailed information that we put in there so that we know specifically what kind of contact that patient navigator is having with that patient, how long are they having to work with that patient, are there things that are being resolved, not resolved. And so that has really been helpful for us as we've been gathering data in order to really move forward in identifying the needs and the role of the community health worker. And finally, this is probably what many of you are, which is a health navigator. The qualifications are that they usually do not share condition, demographics, or experience with the population. They require a clinical background such as a nurse, social worker, health navigator, or some related field with a minimum degree. They frequently function as a supervisor for CHWs, and they're supervised by a degreed medical system person. The functions are they provide system navigation, community resource connections, enhance access to system resources, and provide care coordination and case management. May develop or conduct education, may supervise or assist with CHW classes. They advocate for patients' medical conditions, but again, may be limited due to the employer and what their guidelines are. Provide coaching and emotional support, serve as a liaison between academics and community, but provide support and counseling within the scope of practice, and that is extremely important. Design outreach activities, conduct outreach activities and case findings, participate in formal recruitment activities of clinical services. They participate in evaluation, research, and community assessments, and they contribute to evaluation, research plans and activities, and may even lead implementation of evaluations and research. Some of our staff love being part of research. So we are, getting them involved as much as we're able to and much of their time permits, and they've done a fantastic job in helping our research team. So now we're going to talk about how you transform sickle cell care coordination and case management findings under COVID-19. Now, we went into a lot more detail about this last year when we were still in the heights of the pandemic. But because the pandemic is still here, it hasn't actually entered a formal endemic situation, and there could be another one that might be along the horizon, I just wanted to kind of mention a little bit about where we were before things happened with COVID and then kind of what happened once COVID hit. So we had patients coming to the emergency department, the clinic, and the hospitals, and our navigator team was right there. I don't think Dr. Smith did this so far in his presentation, but we had this little motto that wherever a patient kind of was, we were like, hey, we're here, we're seeing you, whether they liked it or not, but we were kind of always there. We are in close contact with the clinic, and we also did home visits and worked with the community. We went to the emergency room when patients came, and we saw patients when they were inpatient. And there was no fear of safety of patients or staff. I mean, we just kind of went where we needed to go, and we made things kind of happen. And then came COVID, and we didn't see people. We didn't know where they were, and we were very scared for them, as well as scared for ourselves, especially those of you that have been on the front lines. There's nothing here that I'm going to tell you that you don't already know. But we weren't sure if they were okay, and we didn't know what to do with them at that time. So this is kind of a complicated side, but the bottom line is we were able to kind of work out a system where we were able to connect with patients via phone. I think I talked about this a little bit, different social media or telehealth campaigns, where we were able to say to patients, stay home, we got you, we're going to make sure you're okay without putting your health and safety in jeopardy. And so, we did kind of transform things. I remember coming into work that Monday, March 16th, that date will be embedded in my brain forever. And I was always like, boots on the ground, we have 1 week to get things ready. And, through the help of some of our staff, we were able to put telework agreements together, get computer equipment assigned to everybody. At that time, we thought we were only going to be gone a couple weeks. We set up daily huddles, which again, we kind of thought, okay, this is only going to last for a few weeks, and then we're going to come back to normal. And we decided that we were going to do daily tracking logs for telecommuters. And I felt that this was really important, and I'm going to tell you why. When people have these conceptions these days, even now, 2 years into a pandemic and in year being 2022, that people that stay at home and work are really less effective. And so I was always concerned that as time was going on, that if we didn't demonstrate what we were actually able to do while we were at home, that, somebody could come in and say, well, you really don't need that staff. We're going to take that away from you. Or you don't really spend as much time as you need to. So to this day, we are still doing daily tracking logs for all of our hybrid or our telecommuter staff. And we have also found that their productivity has actually increased over the last 2 years for the type of contacts that they have with their patients. So if anybody ever comes to me and says, what are your team members doing? We have the documentation. So I kind of talked about this a little bit. I'm not going to really get into this too much, but it's really a way that we've tried to figure out how sick people were, whether they were staying home if they had COVID, they weren't coming to the emergency room. We did suspect early on that we may have lost at least 1 or 2 patients to COVID really early into the pandemic that, probably had not been formally diagnosed with them. I don't feel like we're at this place now. I think we have a really good understanding of how to best check on people and to ensure them that they're safe if they get COVID. And actually, we've had more people get COVID over the last year and a half than we did when the original pandemic started. So I see that we have no questions or anything, so I think we're going to move on to our next segment, which is the supervision and daily responsibilities of a patient navigator program. So we're going to start with a polling question. And hopefully you guys are still into the polling questions. And I don't think I went over the instructions last time, so let me do that one more time. In order to do this, you want to go to pollev.com/VCU Health CME, or you want to text VCU Health CME to 22333, and then once you join, you're going to be able to answer A, B, C, or D. So name 3 components to successfully building a relationship. Empathy, strong communication and trustworthiness, strong communication, advocacy, and teamwork, advocacy, empathy, and strong communication, or none of the above. So I'm actually going to hold off on answering this until the end of the presentation, and then we'll get back to the answer and see how correct everybody was. Okay, our second polling question is, advocacy in all its forms seeks to ensure that people, particularly those who are most vulnerable in society, are able to have their voices heard on issues that are important to them, defend and safeguard their rights, have their views and wishes genuinely considered when discussions are being made about their lives, or all the above. Now, in this case, I'm going to go ahead and give you the answer. And we do have a little bit, most of you have answered correctly, all the above. But it is important to recognize that all of these things are something that you need to be aware of when you are working with patients. So, I talked a little bit about hiring practices and what we consider to be important in a job description. I will tell you that in doing this since the grant started in 2012, I've probably continued to evolve on what I feel is important for education and how we're going to move forward. So now in our job descriptions, we do put that we would prefer to have a BSW as again, I call them navigators, so excuse me, but they are CHWs. But we do accept people with GED or high school diplomas. We want somebody, if possible, to have 1 year of experience as a CHW, and if possible, also to have some background in sickle cell disease. But remember what I said earlier, I am not as hung up as I am on somebody having experience in sickle cell disease as I am having someone have the right attitude and determination to come in and work with this population. Obviously, we have a training curriculum. People can learn about sickle cell disease through this training curriculum. They need to be able to have a really good understanding of families and individuals and have an understanding of ethnic, cultural background, ages, and economic circumstances. I think this is really critical. I find that you could usually gauge how you think somebody may interact with somebody in an interview, but I know sometimes we do get those things wrong. But it's really important to have the sensitivity of knowing there's different cultures and different outcomes of people and their values, and you want to make sure that people are very sensitive to that are working with them. And you also want to make sure that they have transportation and insurance to provide community outreach. Now, that's changed a little bit with COVID. We obviously are not going out still in great groves into the community, but it's still something we want to get back to, and hopefully we could do that pretty soon. When we were able to go to hiring people, we started out by hiring them hourly and not putting in full-time positions. I will tell you that back in 2012, that seemed like the right thing to do. I will tell you now, I think that's probably the worst thing we could do. And the reason why I say that is it really caused a lot of high turnover for people, because most of the time people don't want to stay in part-time jobs. They need health care benefits. They don't really have a lot of accountability. They kind of have like this, I can, work these days and not these days, and, I'm not full-time, and, I'm going to go look for that, or sometimes they see this as a stepping stone to get to the next place. I would say that if I had to do it over again, I would have taken less positions and had more full-time staff. So I really think that that's something to really consider as you're moving forward in developing your program. So I feel we also have evolved again over the last, now it's been longer than 5 years, but we did end up reducing our hourly staff, and at that time converted over to 1 full-time staff person, and then eventually 2 full-time staff people, and now we have 3. I think that was really helpful in relationship buildings and really improving the outcomes that we needed for not only the patients, but the staff and the program. I also talked about how we have our documentation system where we're able to monitor the type of work and the hours and minutes that each navigator is putting in to a particular patient. We had spoken a little bit about this yesterday, how we were seeing that a lot of our highest utilizing patients with patient navigators are not necessarily the same people that are coming into the hospital. And so we're looking at correlations of why that is, and we're starting to delve into that a little bit more with mental health. So again, we focus a lot about relationships, but the relationships are really the cornerstone of quality healthcare. And in my opinion, really the cornerstone of really helping to build between that navigator role and the other staff that we have in the program. And if you look in 2017, the Council of Accountable Physicians Practice, better known as SCCAPE, emphasized that relationships are the #1 factor in quality healthcare. And I think that is why you're starting to see a shift into how healthcare systems are really focusing on that patient-centered approach with patient care. If you have medical homes and you have established physicians in different practices, they're able to spend more time maybe in focusing on the relationship building factor with the patient. Obviously, emergency room doctors are different. They're not able to do that. Although, I will tell you, by having our champions with our emergency room physicians, they are absolutely the opposite of that. They actually have relationships with some of our patients who come in more frequently. They know them, they know the circumstances about what is going on in their life, and by us being able to meet with them more frequently, that has really helped, I think, in their understanding of those patients as they're moving forward and working with them. So 3 key traits of positive patient-provider relationships are empathy, the ability to understand and share feelings of another person, strong communication, where you're able to convey messages clearly and simply, whatever that form needs to be, and positive and knowledgeable, listen and explaining, let me go back again. Positive patient-provider relationships, which is knowledgeable, you listen, you explain, and you're trustworthy. So I kind of feel like we harbored a lot on relationships, so I'm going to go ahead and I'm going to skip past this slide, and for time's sake, I want to get into these 3 traits pretty significantly. Empathy is probably the #1 thing that each of us need to have in working with anybody. All the training in the world will not be successful with a patient if you don't have empathy for them. You need to make sure that somehow you could relate to them. Like I said earlier, I do not have sickle cell disease, but I would like to believe over the years that I have been working with sickle cell patients and listening to them, that they understand that even though I'm not someone who suffers the same way they do, I understand and try to recognize the pain and the challenges that they're going through. And I feel like those relationships have been solidified over the years. I mean, there are times when it's challenging, for whatever reason. The patient might not be easy to deal with. There might be complications that we haven't been able to, deal with. Maybe there's been some undiagnosed mental health issues, and we want to make sure that we're really recognizing the fact that if we're not being empathetic to patients, we need to be better about that. And we need to have patients telling us that. I know that's hard for patients, but if they are going around telling everybody else how we are not taking care of them and that information is not getting relayed to us, how could we fix that problem? Strong communication. I think Joan kind of talked about this a lot yesterday, so I'm really not going to spend a lot of time on this, but I think the patient teach back program is something that is really important, that we make sure somebody understands what they're saying. Please repeat back to me what I said to you. So I'm not going to really spend a lot of time on the communication. But I do want to focus a lot on the trust part of it. There's 3 really main points about this. It's trust, and it's trust. Patient education, making sure that you know what you're speaking about and that the patient is recognizing that you are somebody that they could come to ask questions to. Understanding patients' culture and their personal preferences and engaging that family and caregiver. But most of all, do not lose the trust of that patient or their family. It's really hard to rebuild trust once you lose it. It's something that's really imperative in all of our walks of life, and you want to make sure that you're doing what is right by the patient. Again, you want to make sure you're setting boundaries. Know your limits and the limitations of your organization. Tune into your own feelings. There might be a time when it is really challenging for you to work with somebody because maybe that has something to do with an experience that you had. If that's the case, please go talk to your supervisor, because you're not going to do yourself or anyone else good if you cannot work with somebody because of a conflict that you have. Be direct, but of course, be professional. Give yourself permission to really not have a good day sometimes. There are just some days you're just not going to be doing okay. And maybe those are the days you sit in front of your desk, or there's just a time when you might have to say, I just can't deal with this today, and ask a colleague to help you. I don't think we should make that a regular practice, but there are some times when, you're just not doing all right. Practice self-awareness. Consider your past and where you want to go in your future. Make self-care a priority, whatever that would be. I think Dr. Griffin talked about that a lot yesterday, and I think we need to be good about using those apps, taking walks, making sure you're talking to somebody, making sure you're bouncing ideas off of other colleagues, making sure that when you go home, maybe you turn that phone off. Maybe you have a glass of wine, a glass of water, take a walk, whatever that's going to be. Be assertive and know how to have small talk with folks. I think that is really important. Sometimes you got to just be a little personal with people. You don't have to tell them your entire life story, but you need to make sure that you sound like you're human, because people are going to pick up your sincerity. Again, we want to make sure we talk about boundaries. Know your limits. You cannot set boundaries if you do not know yourself where you stand. Make sure you know what your comfort zone is. Identify your physical, emotional, mental, and spiritual limits. There are just some individuals that you just cannot work with, and that is okay. And it's also okay if patients cannot work with you. So don't take personal offense to it if somebody asks not to work with you any longer. Sometimes that's out of our bandwidth. I understand that. But make sure that if it's possible, that if you really can't work with this particular patient because there's a conflict within yourself, that you're talking to your supervisor about that. Again, tune into your feelings. Make sure you know what they are. Be direct. Be professional. Make sure you're communicating your needs in a style that is comfortable to you, but also feeling engaging to the patients that you're working with. Give yourself permission. There are times when you are going to make mistakes. It is just human nature. We are human beings. We don't have the answers to everything. And sometimes we feel a lot of guilt about some of those decisions. Maybe it's something you said, maybe it's something you did or didn't do, maybe you didn't get around to something quick enough. Whatever that circumstance is, give yourself permission sometimes that maybe you are human and sometimes things just happen. Practice self-awareness. Be attentive to your feelings and honor them. You always want to make sure you honor yourself. Consider who you are, how you were raised in your family role, and how sometimes that could have an impact on how you're dealing with someone else. I know we don't have a lot of time, but I want to just kind of give you an example of an intern that had come to us a couple years ago who was going for her master's degree. She had strong political and religious viewpoints that after her being here for one semester, I had a talk with her, and I said, I really don't think you're in the right field, especially for what you want to do. She ended up dropping out of the program. And I think in the long run, that was probably the best thing for her, because I could not see her being able to really relate to any. She had a box that was so small of who she thought she would be able to handle and work with that there was no way she was going to be an effective social worker. You also want to make sure that your role as a professional can drain on your family. Sometimes leave things at the office, or in this case, maybe leave it in your office and shut the door if you're still working at home, or whatever that circumstance could be. Because of lack of time, I'm just going to go through these really quickly, but there's 8 principles for effectively maintaining professional boundaries. Empower and not rescue. Take care of yourself. Service time is not me time. Don't open your wallet. It is not your responsibility to give people money or personal information or whatever. Don't shift from service provider to employer. Be consistent, be a role model, be accountable. Also, personal safety. Think before you go. Assess your risk by phone before you visit. Now, again, we're in a different world here a little bit, but I still feel like this is something that we need to really talk about. Sometimes we don't know the areas that we're going into, or we don't know the best time to go into those areas, or, we're not really sure where we're driving to. Now, I know GPS is out there and some of these things may not apply, but you still want to make sure that when you start going back out in the field, or if you are back out in the field, that you maybe have that access to a cell phone, that you've talked to the person that you're coming to see, you know their situation, maybe they have pets and you don't like dogs, maybe there's other people in the home that maybe you're not comfortable to talk around. So I think you really want to make sure you know where you're going before you actually get there. You have a right to ask people if they have an animal whether or not they would secure that pet if you're not comfortable. You also have a right to ask people, especially when we're in non-daylight savings time, to maybe turn on their porch light. Would they kindly greet you at the door so you know you're at the right place? Again, especially if you haven't been there before. These are all common sense things, but sometimes we don't think about these things as we're getting ready to go out and do our first home visit with someone, or even our second home visit. Consider sometimes that maybe there's an area you don't want to go to for whatever the reason is, and you could ask for an alternative site. I know we did do this a lot during COVID. There might have been times when we utilized libraries, for example. Maybe it was easier for someone to get there on the bus line, and for whatever reason, the navigator couldn't quite make it out to their home, so they would meet at a library or they would meet at an off-site. I think that that's okay. Make sure when you're going somewhere that you have gas in your car and you know your tire pressure is okay so you don't get stranded somewhere. Have your patient's number in your phone so that it's easy for you to be able to call them when you need to. Wear a name tag. Wherever you're going, most of the time when someone sees you're from somewhere, or if you're wearing a white coat, or you're wearing scrubs or something along those lines, they know you're a professional person. They're not going to have any problems with you. Plan items for your home visit, making sure you have a laptop. Maybe you have a hotspot for your phone if you need to get onto the internet. Making sure you have a phone for safety reasons or for whatever the reasons are. And sometimes you just might want to have that pepper spray or clipboard or whistle with you, because you just really never know. Society is very challenging no matter where you live. I'm not just saying this is in impoverished areas. It can happen anywhere. And have important numbers on you. And also, if you do go out in the field, make sure someone knows where you're going. It should be your supervisor. I used to ask when we were running the grant that the staff put on my calendar where they were going, so at least I knew, and there was certain time frames of times when they had to be back in the office or be not going in the field past a certain time period. Do not park in someone's assigned spot. If you're going to a housing complex, make sure that it's not an assigned spot where someone's going to have your car towed. Keep your hands free with your keys in your hand and walk with confidence. Do not walk through groups or back streets. I know that a lot of this sounds like it's common sense, but I just really wanted to reiterate this because I think it's really important. Things are really changing in 2022, and we see a lot more violence out there no matter where you're at. So you want to make sure that you're being safe when you're going somewhere. Make sure that when you're at a client's home or a patient's home, that you understand the proximity of where you're at and where your door is to get out, and kind of where you're supposed to be during that home visit. And some of this comes back to my child welfare days. So this is kind of some of the things that I learned when I was doing child welfare, which obviously is an extremely challenging job to have. And we would be going out there. We were the intake workers, and obviously not always delivering the best news. So I always became conscientious about where I was in that home. Could I get to the exit if need be? Making sure that I was in a place where it was easy for me to get up from. I mean, if you're sitting in a chair and the chair's kind of sinking and you're not in a way where you could get up very fast, sometimes that can inhibit your ability to get out of a house if you need to. This all being said, none of these things, knock on wood, have happened to any of our staff. But I want you to just be aware of this, because we don't really know the circumstances sometimes when we go out into a home. So you just want to make sure you have all of your I's dotted and your T's crossed. Now, I think we talked a little bit about I statements yesterday. So when you're talking to someone, calmly use I statements. Try not to use the you word or other things that could antagonize somebody. Acknowledge what someone is saying. This goes back to that motivational interviewing that Joan went over yesterday. Make sure that you understand that you've heard what they said, or if you're not sure what they're saying or they're trying to relate to you, it's okay to sometimes just maybe reiterate something back to them so that they can clarify that this is not what they were speaking to you about. Redirect using matter-of-fact and simple direct statements. Keep your physical distance, not just because of COVID, just because for safety reasons you want to make sure you're doing that. Do not reach out to try and touch someone or stand in front of them or turn your back on someone. Everyone wants their personal space, long before COVID came along. So make sure you're very sensitive of that. I really have a problem when somebody's literally like standing here talking right at me. I like my personal space. I think most of us do. But sometimes we don't always recognize other people's personal space. Do not get up while a person is sitting. It's terrible when someone's standing over you talking to you. I think it's even worse when it's someone like us in a professional role and we're standing over a patient. So try to be aware of the fact that if someone's sitting, if at all possible, try to be at least at the same level as them. Trust your instincts. If you don't feel good about something, don't do it. Maybe you might be overly sensitive sometimes to things, but you also want to make sure that you're not putting yourself in a position where you're not comfortable. Again, maintain those personal boundaries. It's okay to have dialogue with patients. It's okay to have dialogue with patients' families, especially in the role of sickle cell care, right? Many times you're dealing with people for 18, 21, 25, 30 years, however long, because of our practices being so small and there's limited amounts of us that are working with sickle cell populations. But understand sometimes where that boundary line needs to not be crossed. Don't be inviting people over to your house or to your children's birthday parties. Making sure you're not giving out your home address. I mean, I know it sounds like common sense type of stuff, but you want to make sure that you're at least addressing these things as much as you're able to, and keeping within the grounds of something that makes you feel human and make you are human. I mean, people want to have humanistic conversations with you. You could talk about, oh, you know what, my son's getting married next month, but you don't need to get into all the details about, where the wedding is, how many people are in the bridal party, where they're going on their honeymoon, what they're having for their reception, who's making the cake, where did you buy your wedding dress. There's some points and times where you feel comfortable of what you share with someone, but just make sure that it's not really crossing that line. And if there is a problem, make sure you report it to your supervisor immediately. Sometimes you just need to take a step back and let someone else handle the reins for you. That's what we're here for. I will honestly tell you, I think my staff handle things pretty much on their own. So when they ask me to step in, I know there's usually a reason why they do that. I mean, we've had, the same staff, for a long time now, and they know the patients, they know what they're doing. And so sometimes if they ask me to intervene, I know that there's a particular reason to do that. But don't be afraid to talk to your supervisor. Even if you don't want them to intervene, sometimes you just need to bounce things off of somebody and be able to get a different perspective. Or like I said, just give that 5-minute phone call to me to say, hey, I really just need to vent to you because something is really upsetting me. And then sometimes you could just move on. So when we were doing the National Institute of Health grant back in 2013, we had really thought about how do we make things safer for patients and how do we make things safer for staff. And we thought it was only fair that up front, patients kind of knew what we would do for them and what we wouldn't do for them. And so we kind of came up with a patient do and don't list. And I think it's some of the things I've already talked about, but I want to make sure that we kind of go over this again. Patients tell their health navigators what they need from them to stay healthy. That's fine. Patients should be ready for their visit. Make sure your pets are locked up, you turn on your outdoor lighting, and you meet that navigator or community health worker at the door if at all possible. If you have issues and you do not feel safe with your navigator, this is a patient signing this consent, this little checklist, you need to contact their supervisor, and my name and phone number was listed on that particular sheet. You can only see them during scheduled work hours and regarding work-related matters. We set boundaries, I think, where patients could be seen between 7 a.m. and 7 p.m. in the community. Those are the only times we were willing to do that, Monday through Friday, and we only would see them for work-related matters. The don'ts that we went over with patients: the patient cannot give or take money from you. They do not provide, the community health worker will not provide rides to you to go places. I'm sorry, I switched these out because sometimes we've done this talk for community health workers, and now we're doing this talk. So I'm sorry for the acronyms being a little bit different. But the health navigator cannot give you medication or count your medication. That is really, really important. We had a grant at the time where we were trying to see compliance for hydroxyurea. The patient had to count the medication. We would not count the medication on their behalf. The patient cannot work for you or complete tasks that are not part of your working relationship with the navigator. We didn't want somebody to say, hey, by the way, Johnny, since I'm your navigator, could you please come over and do my yard work this weekend? Now, I know that kind of sounds a little extreme, but there's always that one situation where you might, find somebody who would step over those boundaries. So we would go over this particular do's and don'ts list. We would have the patient initial each box next to it. We would have them sign it, and we put it in their file. We never really had to use it, but it was something that kind of made the staff feel better because they didn't have to really get into things. They could always refer back to that particular list if they needed to, or they could say, if you remember, I gave you a copy of this list. I kept a copy of this list. If you have any problems with this, my supervisor's name and number is on there, and you can give them a call. So I want to just kind of go over one more time some health and home safety issues, and I know we're getting close to probably wrapping up, and you've been listening to me for a while, which I truly appreciate, but I still want to make sure that we go over these things. We want to establish procedures and processes for reporting concerns within your department. Make sure that as you're putting a team together and as we're getting out of COVID world and things are starting to happen where people are going back out into the community, that there's an understanding of what you expect from your team and what your team expects from you. Make sure that if there's neglectful situations of a patient when you go out there, that those are being addressed. Did you go through your medical appointment? Have you had your dental appointment? Go through personal hygiene tips. What are your nutritional needs? A lot of these things are found in those public domain handouts that we've given you. Many of them by the CDC. They're really easy to read and understand, and they're really easy for you to go over with somebody where you're not making them feel like, they're children and they shouldn't be talked to in a certain way, but you're still providing them the information that they need. Make sure if someone's in an unsafe living condition that you let the team know, and somehow let's try to figure out how we could get them in a better place. Sometimes our patients are in abusive situations, whether it's physically or sexually. We talk about that. It doesn't happen often, but we have brought up some members of our team or within our team where we have felt some of our patients might be being exploited. Make sure that you talk to your team members and figure out the best way to handle that. Is it reporting to Adult Protective Services? If they're children, is it through child welfare? Making sure that you're protecting the needs and the safety of the patients that you're working with. A lot of time, there's emotional abuse, name calling, people getting made fun of, putting people down. Several years ago, we had one of our patients who is gay was really being taken advantage of by somebody. It was really horrific. And we worked hand in hand to get that particular person out of that situation and get them in a place where they were safe. But it was also very challenging because of the way that dynamic of that relationship was. But ultimately, that patient is doing much better now, is much more in a stable situation, but it took a lot of work to actually get that patient to that place. Mental health, we've talked a lot about this. I feel in sickle cell patients in general, there's a lot of undiagnosed depression and anxiety. And, if possible, I know, again, like we talked about, it's really difficult for African Americans to reach out for therapy, but try to build relationships with your patients to the point where you can get them to be seen by someone. We would love to have them seen within our team, within our mental health team, but if that relationship doesn't work out or there's some kind of conflict with timing, our mental health therapist will work in finding another place for that person to go. And a lot of times, when patients are reporting poor sleep, I forget who talked about that. It might have been Dr. Joy on Tuesday. Make sure, that we're figuring out why that is happening and trying to get them the support and the assessments that they need. Sometimes our patients are taking care of abuse financially. I hate to say it, but sometimes it's by their own family member. They take their checks. They might be the payee of their check, but they're not paying their bills. We have found that to happen several times, and we've had to intervene and help take action for that. So that is something that I think is probably not reported as often or is looked at as closely by a lot of us, especially if we're not maybe meeting with those patients on a one-on-one case management level. But if you have that case manager involved, you should be able, through the relationship building that they do with that patient, be able to figure this out and intervene. We find that happens quite a bit. And we also need to make sure that our caregivers are taken care of. Sometimes there's inappropriate behavior by the patient, by the staff, and we need to make sure that we're doing the right thing by the people who help take care of our loved ones. So I kind of touched on this a little bit, but I'm just going to go over the AIDET principles because I think that is really best practices for when you're doing home visits. So you want to acknowledge all family members, you want to smile, you want to be pleasant, you want to make eye contact. You're going into someone's home. That's a lot to ask of somebody. And I remember having many discussions about this with our team over the years. They're like, I don't want somebody coming to my house. I don't know why you would want us to go to their home. I would find that very intrusive. All of those things are probably true. But sometimes, in order to really do right by somebody, you kind of need to see them in their own environment. So sometimes by going in their own environment, there might be things that patient or that family member didn't even realize was happening that you were able to see as a new person. Make sure you introduce yourself and tell them why you're there. Don't make it out like it's something really bad that you're showing up at their home, but that you're there to really support them. The duration of the time that you're there. At the start, state how long your overall visit is going to take, and during the visit, indicate the length of the task that you need to go over. Explain all processes and procedures so they know what to expect, and thank the family for agreeing to meet with you in their home for their time and answer any remaining questions. Again, I feel like a lot of this is common sense, but especially when you're newer to the field, you want to make sure that you are learning that etiquette and that somebody is helping you to become familiar with that etiquette so that you're not seen as an intrusive person and you could do the job that you were hired to do. Because I have really always firmly believed, because of the work that I've done over the years, that you really see somebody as their true self when you can see them in an environment that they are comfortable in. A sterile clinic place, an inpatient hospital bed, an emergency room, wherever the circumstances are that you typically might see somebody, you're really not going to see them as their true human being until they're in the comfort of their home with their feet propped up and their slippers on. And I'm kind of being funny when I say that, but you're getting to the point of what I hope that I'm trying to make. And again, we've talked a lot about advocacy, but the role that we have as clinical providers and behavioral health specialists and case managers is really to advocate for people and to be the voice for themselves that sometimes they're not able to do. You want to defend them if possible and protect their rights. I find that happens a lot within our team, and that's why I'm very respectful of the team that we have, and I appreciate all the times that they come out and say something against what we might be trying to direct a patient to in a certain manner, because they have that relationship. Have their views and wishes generally considered when decisions are being made in that multidisciplinary team. We're pretty much functioning at that capacity these days because of the way hospital programs are being developed, the fact that we have built medical homes. There's a bunch of people sitting around a table, and you want to make sure you're taking those needs of that patient, and I touched on that earlier. But, advocacy really is a vital role of case management practice and the primary role of a professional case manager. That is really what we're here to do, and we want to make sure that we follow the things that have been written in the literature that are describing case management of the essence of the relationships that we're trying to build. So there are 4 different stakeholders that assist with driving the importance of advocacy to focus on the quality, safety, and cost of services and resources. We have the Patient Protection and Affordable Care Act of 2010, which is, I think I mentioned earlier, how we really started this whole program with Joan, Dr. Smith, and myself. We have value-based purchasing, which is really becoming on the horizon of how we're going to be reimbursed for the services that are being provided, which is why we're starting to build those really important relationships with the MCOs. We have the Institute for Healthcare Improvement, IHIs, and we have the Triple Aim, which is not as strong as it used to be, but it's still the National Strategy for Quality Improvement in Healthcare. These things are really important as we are moving forward, and we're advocating for patients as best as we're able to. So advocacy has been discussed and defined in great detail in the public and social policy literature. In case management, it has not been reviewed and described as comprehensively as it should be. But we're working towards improving that. And I haven't honestly looked at the literature lately, so there could be some new articles out there that I'm not familiar with. So if anybody knows of anything, please let me know, because I do want to make sure that what I'm speaking about is the most updated information. But the last time that I had checked, this has really not changed much over the years. We want to make sure that we're simply noting the similars to friendship, to open communication, transparency, respect, truthfulness, and trust. And I think when I'm talking about this, we've already focused a lot on the trust piece, but the transparency piece is also important. We really need to be upfront with patients. We need to really tell them, hey, I can't write this prescription for you, and I'm going to explain to you why. Or, I had the DEA office, which does happen periodically, come check on high prescribers. And they were really questioning the quantity of these drugs. We haven't really reviewed that lately. Let's look at maybe a different form of practice that might be able to help you. That is really challenging for a provider to be able to have that conversation with a patient. And it's not because they're accusing anybody of anything, but it's really because sometimes they're saying, I think we need to look at different avenues for your care. Similar to counseling, when applying listening, attending, supporting, and empowering skills, that's exactly what we are doing when we're advocating. And we want to have similar to teaching when involved in practice, guidance, and sharing of information by more knowledgeable individuals. Sometimes we don't know everything. I don't know everything, and I don't think anybody sitting in this audience knows everything. So I think many times when you're bouncing ideas off of other people that you're working with, or maybe people that you don't necessarily work with who might have a different perspective, they might be able to give you ideas and solutions on how you could better deal with not only your program, but some of your more challenging patients. So we have one question. Are there options if the patients do not want home visits? Yes, I would say that if you do want to see somebody outside of their element, that's where I would suggest having an alternative meeting spot. I suggested the libraries because they're usually free. It's usually, most libraries are large enough that you could go somewhere where you're not really breaking someone's privacy. If the person has the financial means and maybe they want to get out for an outing, maybe you could agree to meet them at McDonald's or Chick-fil-A or Taco Bell or something. But you want to make sure that that suggestion maybe comes from them and it's something you feel comfortable doing. But absolutely, I guess I'm just stressing that sometimes you want to see somebody in an element different than where they come from. I do think it's really important, and I think you should think about yourself, how you are in a professional setting and maybe how you are when you're not in a professional setting. And if you really want the help of someone who's working with you, sometimes they need to see who you are outside of that doctor's appointment. And it really might help them kind of go through some different situations with you that maybe you didn't realize that there's help out there for things that you've been challenged with. There was a young lady that we had been working with for years. She had been living in this apartment complex for 9 years, and her air conditioning system had not been working properly, off and on for 9 years. Every time she reached out to the apartment management, they ignored her. We wrote one letter and told them that we were going to call them and follow up with them, and they had her air conditioning system fixed within like 24 hours. That's a horrible thing to have happen to somebody. But as much as she was trying to advocate for herself, I think if I had not seen her, I think it actually was our navigator, who had not seen her in her home setting, we might have never known that that was something that she had been battling with for 9 years. So, thank you all very much for your time. I know I've been speaking a lot. We have another beautiful animal that's here at the end of our presentation, and we are going to take a break and come back at 11 o'clock, and we will see you then.